Welcome everybody to our Penn AI Tech monthly webinar. The Penn Artificial Intelligence and Technology Collaboratory is an initiative funded by the National Institute on Aging. And this month's webinar, we are very happy to have with us Dr. Kelly Gleason, who is an assistant professor at Johns Hopkins School of Nursing. Her work focuses on smarter ways to integrate the patient and the care partners' voices into the healthcare. She has expertise in patient portal innovations, integrating patient-reported data with electronic medical records, and improving digital literacy for low-income older adults. Currently, she leads the development and analysis of a novel dataset to understand patient portal use among older adults and with and without dementia at Johns Hopkins Medical Institutions. I want to remind you all that you can post your questions in the Q&A box, and after Dr. Gleason's talk, we'll get a chance to answer some or all of these questions. So again, Dr. Gleason, thank you so much for joining us. I'll hand it over to you.
Hi, everybody, and thanks so much for being here. I'm super excited to introduce this work to you all. So I'm going to be presenting on patient portal messages to identify and support care partners of persons with dementia. I want to acknowledge that this work is largely supported by an NIA R35 grant. The PI is Jennifer Wolf, and I am co-I with leading the component of building the novel data set, analyzing the novel data set, and acting on it. So I want to start off with why use patient portal messaging to identify and support care partners of persons with dementia. And I'm sure that this group does not come here with these thoughts, but as somebody who has worked with patient portals for a while, older adults and those with cognitive impairment have not really been considered in a lot of patient portal work. It's more how we are leaving them out if we are doing any patient portal work, how they are not accessing the patient portal because low digital literacy if they're older, or issues with different disabilities. And I hope to dispel that and then show why it's a good mechanism to identify care partners. So, as I'm sure you guys have seen by one mechanism or another, patient portal messaging is rapidly growing. If any of you talk to a primary care physician, provider, you will hear from them about their number of patient portal messages if they work at an institution that has the patient portal. It's been published in the New York Times, in the American Medical Association, and in various research articles that really the number of messages is rapidly growing, and it's become hard to keep up with. At the same time, using messaging is very likely not going away, or is not going away. It is an extremely helpful resource for people to access healthcare through, particularly if you think about people with dementia and how hard it is to get them in for an appointment, and all the barriers that come with just getting to the primary care clinic, to the outpatient clinic, sitting down for a while, waiting for a visit, and then in there. Secure messaging as a way to reach clinical care and support is here to stay. And why care partners? Being a care partner of a person with dementia is very tough. Primary care clinicians who play a pretty central role in the initial care of persons with dementia. Even though dementia is highly prevalent, it's growing, it's really just a small fraction of the patients who they see every day. And it's been well documented that they don't feel fully equipped to support these patients, particularly in their non-medical needs, which often show up. Care partners, and this is a nationwide documented issue, care partners are not routinely identified or supported in the healthcare system. And as a result, they have significant unmet information needs. And this, again, has been shown time and time again that they really voice a significant number of unmet needs, and there's resources existing that could help address some of that, but they're not connected to those. Many care partners suffer from burnout due to the significant needs. It's tough to be a care partner to a loved one with a chronic illness, no matter what. With dementia and the behavioral symptoms that come with it, it can be extremely hard. Bottom line, it's really hard work to support somebody with a severe illness in our broken system, and this is very true for dementia. Now, this brings us to the patient portal. What we see, and this is in a cohort used at our health system of people who had at least 2 visits in a 24-month span, and people who had dementia diagnosis. And for this particular subsample, it's people where we had the noted date of when they were diagnosed with the dementia through the problem list. So it's listed in the problem list for nearly everybody. But in terms of did we have the actual noted date? Do we know when it was diagnosed? That's a smaller group. So among these persons, what we see, obviously this blue line is time of dementia diagnosis. The gray line is average number of portal sessions, and we define a session as logging in and conducting at least one other activity in the portal. The orange line is average number of messages per month and these are among active patient portal users. We don't have the denominator reflected here for the gray and the orange line, but it significantly increased after the time of dementia diagnosis. And the blue line is something that our team created. It's a patient portal activity metric, and this takes into account number of patient portal sessions over the number of encounters that a person had. So you might think, oh, it's only an increase because they're interacting with the healthcare system more, but even after we take into account their encounters, it's still drastically increasing, which shows that, well, not drastically is probably a word, but it is significant, particularly around months 4 to 9. And this is all to show that, understandably, after diagnosis, people are leaning on the patient portal as a way to coordinate care, communicate needs, schedule appointments. It's being used. And I need to go back just to clarify something. This is among both patients and shared access or proxy users. So we didn't separate the two in this graph. But here is among just shared access users, meaning proxy users, so not the actual patient, but somebody who is registered as a proxy user of their account. And what we see, this blue line is persons with dementia, the orange line is persons without dementia, is that among portal accounts that were used at least once during the 5-year period that this data set covers, going through October 2022, the number is lower than you might expect for people who have a condition that's associated with progressive cognitive impairment. But it is higher among persons with dementia than persons without dementia. And when you look at the patient portal activity metric, again, which looks at patient portal sessions over encounters, you see that that is increasing too, and more so for persons with dementia than without. So building on this, what our next question is, well, we're assuming that it's the care partners using the portal on the patient's behalf, but because shared access registration is low, we don't know that for sure. So we analyze threads of patient portal messages of persons with dementia. We self-define a thread. There is not some marker in the patient portal that says directly whether something is a thread or not. But we defined it as within a 7-day period, if a patient messages a provider, the provider responds back, and the next response continues to be about the same issue rather than a new issue. What we found is that the majority, so about 63%, were definitely sent by a care partner based on the language used. 31% were definitely sent by a patient, and only 8 total threads came from a shared access account. So this shows that the care partners are really often the ones using the patient portal on behalf of the patient. We found that it was most usually an adult child messaging in cases where it's a care partner, and then also often a spouse. And among adult children, it was more likely to be the woman adult child, and to the point where even daughters-in-law were more likely to send messages than sons. All mostly women team thought that was interesting. So what we find is that care partners are using patient credentials, and I want to make sure that we're putting this out here loud and clear. This is totally understandable. We do very little across most healthcare organizations to help care partners get set up with shared access easily. There is a pathway for it if you are a parent of a child that is very easy to follow and makes it, if anything, more doable to use your own patient portal account to access people who you take care of. That same pathway is just a lot more difficult for in the case of older adults, especially when the older adult it has reached the point of cognitive impairment that they're not able to sign the paperwork themselves. However, this is a big problem. The patient portal is increasingly used to collect patient-reported information, including legal documents, communicate about the patient's health. We need to formally know who is providing that information. We can't assume that it's a patient when it's actually somebody else. And we're also finding that these are really posing legal and ethical challenges. So building on this background, we are in the early stages of building SmartRep. And SmartRep is smart automation to respond to patient portal messages. So what we're planning, we're in the early stages, so we're doing some of it, is use natural language processing. Right now, it's a rule-based algorithm. In the future, it might be machine learning, and I'll get into that later, to process and act on electronic messages from care partners of persons with dementia. And we hope that to build this in a way that both ensures that they're recognized, identified, documented, known, which really sets the stage for us to be able to support them, and that they then receive the resources they need to manage care. We want to do this in a way that reduces clinician workload, does not add to it, and does not create added liability for healthcare systems if it misfires. So as I'm going to walk through an example of how SmartRep could work. So a message is sent from Lisa's patient portal account. There is no identified care partner in the chart for Lisa. She's an 80-year-old woman with dementia. The message says, "Hi, Lisa fell yesterday. She tripped over a rug. She is still walking okay with no injuries I can see, but I wanted you to know. Thanks, Martha." We see that Martha is the final name listed on the message, which is usually where the sign-off is. And obviously Martha is not Lisa's name. So that's a flag that it might be sent by a care partner. We also see that Lisa is used closely with a she, indicating a third person pronoun, indicating that this message is likely not sent from Lisa. We also see the combination of rug, fall, and tripped, indicating that the patient fell, and there might be some environmental factors, which we can educate and help on. So we're able to, from that, send resources that do not require a clinician input. We can deliver resources on supporting care partners, including locally available programs. We have one that's called to care at our health system that could be used more than it is. There's city resources available. We also send resources on strategies to prevent falls, and then instructions on how the care partner can register for proxy access to the patient portal so we know who we're communicating with, and we can reach them directly to provide support that they might need. We also deliver a questionnaire with questions matching Epic's patient contacts form. I'll get into that next. So there is a form, and I should put out there, I'm using Epic a lot. It is what our partnering health systems use. It is what we use. SmartRep is ideally being built in a way that could plug into any electronic message from a care partner, but parts of it that have to do with care partner identification and shared access are specific to Epic. So what you see here is that it's a form that's this is from the clinician view. So when a clinician views this chart, they're able to see this information for their patient contact. This is my own chart. That's my mom. So you can see this is outdated. It should be my husband who lives in the same state as me. And it has different questions to better understand the caregiver and the caregiver's role for that patient, and also how to communicate to that care partner. So the patient portal can easily send a questionnaire that exactly matches this contacts form. And it can even take that questionnaire that's filled out and directly uploaded into this context form. So it just needs to be signed off and verified by somebody, by a clinical staff member, which would really help, because we have done scans of this. And again, this is not unique to our health system. This is found widely. And they're really sparsely populated, inconsistently populated, whose job it is to populate, how many questions they need to respond to. It's all pretty inconsistent. How they can improve shared access, and I know I'm repetitive about this, but it's really widely underutilized, and I'll get more into that later. When it can be used to set the stage for care partner needs assessments, identifying areas for tailored education and resources, and delivering those resources directly to the care partner. If any of you are researchers who focus on caregivers, you will know that one of the hardest parts about doing caregiver research is identifying the caregiver, because there is no formal systematic collection of caregivers. And even though we have that spot in the chart, it's very inconsistent. So we can send information along for shared access to them and help them through that process. There's so many different ways that SmartRep can go on to improve outcomes without needing immediate clinician input. And that's the important part of this. We know that messaging is not going away. We know it's being used as a crutch. How can we act on some messages that do not require a nurse practitioner or physician PA to respond, but still addresses those needs? And that way, those messages that they really do have to respond to about changes in medications, hospitalizations, bleeding episodes, that those do get triaged to them and they're able to respond because they don't have so many other things to respond to. So, an example is wandering. You can send resources that support that help them prevent a dangerous wandering episode without immediately involving somebody. Uncertainty about how to provide the best care, and this is pretty common. You can send resources for local programs that exist, which there are. So where we are at right now, we're focusing our initial NLP work on pre-identified areas, really going with care partner identification first, as building the foundation to then support that care partner. And we're also doing mentation and mobility. Those of you who are familiar with the 4 M's of an age-friendly health system will know that those are 2 of the 4 M's. We eventually hope to target all 4 M's and open it up to all older adults to support them in their aging. So decisions we're making, and this is a tough one of rule-based versus machine learning. Yes, we do hope that we can use machine learning in the future. That would be extremely helpful in processing all the differences in dictions used by patients and the different styles. Right now we're at rule-based, and one of our partnering health systems, and this is a reason why SmartRep is maybe more immediately feasible than it would be otherwise, but they already actively use a chatbot called Livy. This is University of Colorado Health System. If you are on your computers and don't have anything to do, you can Google them and play around with Livy. She's there to respond to basic patient queries and help direct them towards making a visit if they need it. And we've talked about this with them and the developer of Livy. That phone has never rang before. I didn't even know it was connected. So if you guys heard the phone ring. So the rule-based for now, it allows a tighter control over the rules used. It allows us to make sure that we're not going outside of our scope. And there's less need for data to train the system, which, especially as we're working with other health systems, is a big thing that in these initial stages we're really just limiting it to what's available in the message text. So, example with care partner identification. And again, why we're starting here, it's a major issue. This is a huge noted gap in quality of dementia care, that the backbone of healthcare for persons with dementia are these unpaid care partners, but we don't even know who they are. It's heavily encouraged through recent policy and and quality guidelines. So I'm going to walk through an example of a test run. And what you can see is that we limited it to ones where the sender, the patient, or a proxy, which, now that I'm thinking about it and saying out loud, we could really just limit to patients, since the proxy people, there for support, but not in this example. The message type. So we kept it broad for this one, but really the medical advice requests are where patients are most likely to type in the free text that allows this to work as best as possible. For medication renewal request and the appointment request, it's unusual for a patient to put any free text in there. It's a template. And so we have different specifications for how to tell if it's from a child, a partner, or a grandchild. And we applied this to almost, a little bit over 3.5 million messages from 36,000 patients, all over the age of 65, those both persons with dementia and without dementia. And what we found in this test run was that 31% of all patients had at least one message sent from a care partner. And you can again see that a lot came from a child, decent amount from a partner, some from a grandchild, and some were, have a use of third person pronouns, but we couldn't tell for sure. So I want to give examples of when the algorithm failed. And I did realize this morning when I was going over that I only gave examples of when it thought that it caught a care partner and was wrong. I don't have examples here of when it did not catch that it was sent by a care partner, and that was an oversight. And so what you can see is that older adults, this is like pretty common, they mention their spouse in the message, but it's not because that person sees the spouse or anything. It is just them telling their story about their healthcare and how their spouse is heavily involved. Thanks for the referral. You have heavily eased my wife's mind. My husband has me worried about this new medication. So I will get into this later. There's obviously ways that we could look for the older adults where same-sex marriage is less common. We could just do it by, if it comes from a woman and references husband, then it is not a care partner. I do think that if ideally it would also include sexual orientation, but that is famously inconsistently collected and would almost need to be its own thing separate from care partner identification to get that consistently documented. So examples of when it correctly labels, I hope you're well. My mom's doing okay. Most evenings she seems scared. It lasts about 30 minutes. She hasn't been able to explain. Hi, please let me know. I guess I'll answer questions afterwards. So some of the reasons why this is hard, you can see that even though 31% of patients had at least one message from a care partner, a smaller proportion of all messages had a care partner identified in the text. And I think it's likely that it should be a higher percentage if almost a third had at least one sent from a care partner. So one of the reasons is definitely probably that it's looking at individual messages versus threads, and how to define a thread is, without doing it manually, can be a little bit hard. You could use time windows. You could use looking at time between the patient to provider to patient response, but we haven't done that yet. But it's very typical that's only in the first message of the thread that the person fully introduces themselves in the situation, and then the follow-on messages are shorter responses just to confirm with the provider. The spouses, that is something that, there's a clear solution to how we could go about at least getting some of them. But another thing that we're thinking about is, well, if they do mention their spouse and they mention, then that's, and we send a message, hey, care partners are very, very important parts of your care, and we want to make sure that they're noted in the electronic medical record and that they're registered for shared access. That's actually a way that we could get, particularly for persons with dementia, it's a way that we could get people set up for proxy access and identified before it gets to the point that it is the care partner messaging on the behalf and not the patient, because the disease has progressed. So, yep. And I kind of touched on this, but thresholds for sensitivity, specificity, positive predictive value, overall accuracy, I mean, it's going to depend a little bit on where we see our misfires happening as we continue to develop and test this model. If it's not specific enough, how bothered is a patient by a message that was misfired, but still useful? And in a case where a person does message about, oh, my husband and I were on a walk and I got dizzy. Well, it's all right in that case to say, hey, did you want to get your care partner set up with a patient portal? We see that you have one. But sometimes people message, with my wife's recent death, I've really gone behind on medications to the point where I haven't refilled for a while. And in that case, sending a message saying, hi, we want to make sure you get your care partner registered. Well, that could be devastating and lead to an understandably upset patient. So, not sensitive enough. If we don't identify care partners when they are sending the message, and if we aren't, delivering resources and making sure that we do our best to get them identified, then that could be bad too. So we don't have specific parameters set up yet. It's going to be iterative as we do our development and testing. So what a message triggered when a care partner is identified might look like. Hi, thank you for your message. Insert different clinical protocols, and then keeping kind of broad language that persons with dementia often have care partners and they play a huge role in their care. To provide high quality care, it's best if we know who the care partner is, and here are some ways you can do this. So we think that by keeping the broad language, it might make it that, again, if it misfires and it isn't a care partner sending the message, but there's still a care partner involved, it's useful. And this graph is not my work, but I thought that it was helpful in thinking through how to make sure that you don't lose any patient's trust when you're doing something like this. And what you see is trust in AI over time. And again, until we add in machine learning, this cannot be classified as AI. And that has been reiterated to me a few times. So I'm not trying to say that, but loafing is actually when a person overly trusts AI, and anything that the AI gives them, they take as truth. So we don't necessarily want loafing, and nor do we want opposition or aversion to any message sent by SmartRep. And where I think it's okay for people to be is somewhere between appreciation and vigilance. And the effective transparency can help with both of those things. And so we do envision being transparent in the message and having some bottom text. This was automatically sent based off of content that we identified in the message. If this is urgent, please see, please follow this protocol. And if it requires a medical concern, a provider will still see it. So I want to put SmartRep in the larger context of a learning health system for dementia, which is kind of the bigger body of work that this team is doing with the R35. So this is a table as in Alzheimer's and dementia from a paper led by Jennifer Wolf, and our entire team was on catalyzing dementia care through a learning health system and consumer health information technology. And you can see that there's several issues and challenges to dementia care. And one of them is really engaging care partners and this issue of them not being identified, assessed, or supported. So anything that we do to help them, we first need to make sure that we know how to reach them. A learning health system would be inherently observant by definition, and it would seek new information and data from multiple sources. And so as true learning health system for persons with dementia, would be able to leverage the input directly from care partners. And again, when we think about opportunities to leverage patient portals for dementia care, the first thing that we need to do is make sure that we're appropriately communicating with care partners in a way that's known through official access. So we did a scoping review of the literature on how care partners are accessing the patient portal, and this is not just in people with dementia, it's overall. What we found is that registration is low across the board, but that others who have done message analysis have similarly found that care partners are using the portal just through patient credentials. And when people did officially have shared access, or when we saw high rates of care partners using the messaging, it was in populations who needed help navigating the health system, which is not a surprising or shocking finding at all, and directly relates to this body of work on persons with dementia. But when people did have shared access, both care partners and patients voiced many, many benefits of shared access. And the only issues that we saw were related to patients feeling like, well, there's stuff on my record that I don't want, my children to see, or even my wife to see. And, my neighbor's managing my care. I don't want my neighbor to have access to my financial information, and if I needed help covering medical bills. And so there's this clear need that people want shared access support, that it's helpful, but registration is hard. It's not, and this is another thing we found in this review, very few organizations are doing things to help particularly older adults get set up with shared access. And what we also see is that there's really a need for more nuanced access to the portal, which is possible through the way that most health systems have their patient portals set up, but it's not possible if you're just using the patient credentials. Then you are going to see everything, and the person's going to have access to all of the health history and all the customer billing information and such. So we're also involved in an effort spanning multiple health systems nationwide to increase shared and proxy access. And the reason why I want to share this, so each line, this is real data, and each line represents a different health system. We do keep private which health system these are. I mean, I could give you which 5 they are, but not which one is each line. And it's the percent of, what you're seeing is that it's the percent of patients with a registered care partner each month. And what we find, and we hear loud and clear from both the health systems that are having an issue, and that's where you see the yellow, gray, and green lines, and even the health systems that have shaky months. What they say again and again is our clinicians are already so overwhelmed with patient portal messages. And then at the same time, staff has high turnover. There's all these little different things in outpatient care that make it that the last thing you're thinking about is whether or not your patient's care partner who's there at the appointment, talking and everything, has shared access. They said it's not an organizational priority. It's not something they know long-term is really important. It's that at the actual moment, people are so busy. They have so many messages, so many patients, so many things to deal with, that anything we can take off the plate by doing something like this, automated responses, encouraging shared access without having to directly involve a clinician or clinical staff each time, would be a huge help. So, to conclude, care partners with a person with dementia play a pivotal role in navigating their care. A way that they do this, based off of the data that we have, is through the patient portal. Yet we aren't helping in, getting them set up with shared access, and we aren't routinely identifying and supporting them when that the message content is clear that care partners are using it and they're giving their names. So SmartRep is a way to both improve the quality of care for persons with dementia, better support care partners, and hopefully do so without adding to clinician burden. And I want to make sure that I acknowledge my entire team in this work. We span multiple professions and multiple different backgrounds. And I can't believe that I don't have a picture here of our star, which is MJ Wu, who's the data analyst who works very hand in hand with me on these analyses. So thank you. And I'm going to open it up for questions now. I know I saw one oops, sorry, never mind. Dr. Damaris is going to.
Thank you so much. This was such a great talk, and it generated, I think, a lot of ideas and questions. I'm going to go through some of the questions here. So the first one is, has there been work with your data on content analysis of the patient messaging to understand what messages can be automated versus not, and what kinds of conversations have been submitted?
So yes, one way that we've done this analysis so far is doing a content analysis where we label like the chief concerns that care partners have. And something that we've had a big conversation about based off that content analysis is that a lot of the messages, and this is, to medical advice requests, when there's a separate one for medication prescription change, a lot of them for persons with dementia are about medications. And there's different ways that we think through what could be automated. And there's things that that would be great to automate, like, the value of deprescribing, which we know is underdone, ways to help manage medications, like using pill boxes that are with days of the week and different strategies. But at the same time, what we're initially trying to do is hit things where we are not, that are limiting the risk, that we are overstepping on things that we really need a clinician input on, and might be specific to that patient. So that's like the main thing I would say is how to deal with the medication management, which is so prevalent.
Another question, and I know you didn't necessarily focus on that aspect, but with patient portals now, there's a lot of discussion around patient-generated data from wearables or sensor data, things that people use outside the clinical system, sometimes completely on their own. And there's been discussions about whether and if those should become part of the electronic health record or just a patient record. And I was wondering if you had any thoughts to share in terms of the role of patient-generated data in formal systems of care.
So, we're right now pretty deep into a systematic review of looking almost like exactly like that. And I think what's hard is how to do it in a way that helps clinicians better support patients and identify when they might need a visit or might need a change in medication or treatment, without creating like one more enormous data set for them to look at that might be full of depending on what type of patient generated data it is, it might be erroneous at different times, and dealing with those false buyers. I think that there's obviously times where it works well and it saves patients from needing to go to the urgent care or get to the point that their condition is worsened. But it also is one more piece of and this is maybe this isn't exactly what you're asking, but it's hard, is that I think patient reported information in general is something that people have different opinions on. A different body of work I do is entirely on patient reported information following an ED visit. And the trust in that data can significantly vary by who you ask and what the purpose is. And there's actually legal concerns of putting data into the chart as something that a clinician needs to act on, that was put in there by someone who was not trained in how to by someone who is not trained in medicine, even if that's from a medical assistant to the secretary at the clinic that is coming directly from the patient, and how to deal with that. So I don't know if that actually answers your question, Dr. Damaris, but it's absolutely complicated.
Yeah, I mean, it is definitely a complicated issue, and there's so many implications, as you pointed out, including issues around liability and accountability and the quality of information that comes from these sources. We have another question, whether you're aware of any work on assessing technology barriers for cognitively impaired patients to use or access patient portals.
So that's an interesting question. There definitely has been work. there definitely has been work on assessing the barriers of persons with cognitive impairment, and whether a digital literacy test should be something that a person takes and whether to support them or not. But Mr. I'm trying to think. Dr. Williams, Mr. Randall, Dr. Randall. I don't have your full title in there. What I've seen from digging as deep into this as I can is that when there are significant technology barriers, that is exactly when the care partner comes in to help the person with cognitive impairment, to the point where it's almost like our best way to overcome technology barriers for people who are cognitively impaired and unable to use digital technology, which is not the case for all persons with cognitive impairment. Our best bet to overcoming it is to figure out if they have a care partner and get that person involved and signed up for shared access as soon as possible. And we do, for kids, it's automatic. It's for older adults where we really make it as hard as possible.
I wanted to ask you also about care partners. In some of the work we're doing with hospice and end-of-life care, there's sometimes the case where there's more than one care partners for a patient, and there can be some challenges at times in terms of a misalignment of preferences and a misalignment not just between the patient and the care partner, but among the care partners themselves. So I'm wondering if you've had any experience in your own work with that, or if you see the need to identify the primary care partner when there's cases of multiple care partners.
So absolutely. And in the dream world, almost just as much as like a assessment of digital literacy, I think that almost as soon as a patient receives a diagnosis like that, documenting who their I'm trying to think. What we call it is like a digital advance directive, or there's a cooler name for it. I can't think of it right now. But the same way as we have people, when we're concerned about end of life, fill out an advance directive that says what they want done and who their healthcare decision maker should be. We don't ask, who are you okay with being the person who communicates on behalf of you, the patient on the patient portal? Who should who are you okay with accessing it, viewing it, and such? And what's happening right now is that that's just informally happening through people using patient identity credentials. And when I talk to a lot of us, I'm sure almost like half of us on this call have taken care of a loved one with dementia or chronic illness. And we all assume that we have their best interests in mind and that we're doing as it was. But really, if we're saying we want our older adult to be on more medications, we're having issues doing the behavioral management, maybe at that point they want a different sibling involved, and it was somebody who was would rather try behavioral strategies. But we don't know right now, and it's just the whole digital health directive thing is just not happening. We don't ask patients proactively who we want who they want to have access to their portal in the event that they become unable to use it themselves. And so, in cases where the daughter-in-law is using the patient portal, which we see a lot, I know that there's no way my mother-in-law wants me using her patient portal in any event. I don't there's no way that my mom wants her own daughters-in-law to do it. So it's just something that we have to start proactively asking to make sure that people, because as the portal is used as a way to coordinate, manage care, make decisions about prescriptions, and that's all happening over messages, over visits, it needs to be done by somebody who the patient wanted to be in that role. Hope that answers your question. I know it's kind of different.
Oh, no, absolutely. We do have time for a couple more questions if folks want to enter anything in the Q&A box for us to address. And while this is happening, I guess another question is in terms of future work and where you see some of this great work leading into, and if any of this would lead to perhaps redesigning or reconceptualizing the patient portal.
So my understanding is that is that most both, you know, the electronic health record vendors are realizing, and I've heard this directly, are realizing like, okay, you know, we created the patient portal, we created messaging, and now providers are totally overwhelmed. This is like way too many messages. People are doing it on their off hours. They're getting messages at midnight that really require urgent care, making it difficult to relax. And so there's been a few different efforts to try to manage patient portal message burden already. One of them, not to put this down, but you know, one thing that's been done is that if a person writes back thanks, then the thanks is hidden, and the thanks isn't shown because the thanks doesn't need to be responded to, doesn't need to be one more message. And I'm not trying, I'm happy that anything is being done, but at the same time, like the things weren't what was bogging down the person. It's all the million things, including, you know, things like, hey, I'm bringing my loved one in for an appointment. They need a wheelchair, and it's really hard to get to your office from a wheelchair. What do you recommend? You know, that's now something that maybe used to be called into the office, but the appointment's Monday at 8 a.m. You know, staff it's just staffed Monday through Friday. So all of a sudden the clinician's responding to it. I think that the more that for non-medical needs, we can figure out ways to automate responses and to best as possible address it, or direct patients to a different source of information for that. You know, for example, for major health systems, if you're asking any question that is related to parking logistics of attending the appointment, there probably is a source there to help you, and they're probably not accessible through the patient portal. So just automatically, when you see that sending that message, that saves one thing for the person to respond to. And that's, you know, in our kind of initial interviews with key stakeholders in this work, directors of practices, clinicians themselves, medical staff who does the initial triage of messages. That's something that we hear, is that if there is some way to knock out the non-medical needs, that would be an enormous help. Ooh, you're on mute.
Sorry about that. Related to that, we have a comment in the Q&A box from Dr. Koppel, who says he has about 13 patient portals. The med list on each is very different. And even though he's a professor of medical informatics, he can't fix it. The nurses say only the doctor can change it, and the others do not seem to allow patient editing. So if he were helping someone with Alzheimer's disease, the problems would be even worse.
Yes, and just on the same on the same level, people who are actively involved in our work on our team, like that multi-health system study that I showed where we're trying to increase shared access, like they themselves are like, I am trying to get shared access for my loved one. I have cancer and I cannot get shared access for my loved one. I have tried, I have submitted all this different paperwork. I have faxed a random office and I can't get it. And what was I going to say? I'm just looking at the comment. Though if you're working in a place that has open nodes, there's been some specific interventions lately directly around the med list and making it easier for the patient to do it. But it's crazy to me that is still as much of an issue, while I can easily imagine it. So I don't really have a better response for it than confirming that, or sympathizing that yes, it is really, really tough. And they're not as user-friendly as they could be in some areas.
Great. Well, Dr. Gleason, we want to thank you again for talking to us today and for this really thought-provoking presentation. I also want to remind folks that you can check previous webinar recordings on our YouTube channel. And our April speaker is Dr. Gina Ha Yu from Drexel University, talking about designing AI systems for caregiving and its role on emotional work. Again, Dr. Gleason, thank you, and thank you everybody for attending.
Thank you everybody for listening.